The second is the emerging of the new players in health. The third one is the shift from old development models to new expectations, and for the need of a holistic and up-to-date global health strategy. Now, I proceed to the details of the root causes behind the global health challenges. One is the inadequacy of all development models, where those models do not meet the new demand for speed and quality in health services. And where worldwide we are having populations who are becoming wealthier, more informed, and expecting better healthcare. We face a global financing architecture which has been obsolete since 15 years ago, and it was only focusing on state-state cooperation, NGO, and religious confession interventions. And that architecture was limiting private sector involvement in healthcare, expecting the pharmaceutical sector. But fortunately, we are having emerging players like private sector involved in public health, in sport, and so on. You are having also young social entrepreneurs, new tech-driven initiative too. The other challenge is the health data collection problems, where we do have a gap in data quality, accessibility, and reliability for decision making. We do have also a lack of political commitment and a lack of funding for research, where we have seen that we have had insufficient investment in both basic and applied health research. And worldwide, we are seeing growing poverty and malnutrition, particularly among children under 5 years. Of course, all of us, we are seeing humanitarian crisis and the impact on displacement and the lack of resources and disrupted the healthcare in those crisis zones. After having gone through the root causes, I do believe that there are 9 key focus areas of intervention which can alleviate many of these global challenges. The one I suggest we focus more on prevention than treatment. There is an issue of pollution and the climate change. And here we can, in public health, we can ask ourselves what could be done in recycling and also the waste management globally. There is health policies where we have to set up priorities. We integrate into all programs of development, and we have to ensure good governance so that we get good outcomes of, and of course, we shall be assuring the sustainability financing of our health policies. We still have burden on HIV, tuberculosis, and malaria, but new non-communicable diseases like cardiovascular diseases, cancer, obesity, diabetes, who are already shooting up. Of course, there is also human resources globally, where we are having an imbalance between urban and rural distribution of health workers and the capacity building. Six, we have a problem for mental health and substance use, where we are seeing worldwide increasing of prevalence of mental health disorders and substance misuse. Once again, we have to focus on humanitarian crisis prevention by fostering resilience in health system to respond to crisis. We do have globally an issue of food supplement and nutrition, where we have to address malnutrition and inadequate food supplement, particularly in the developing countries. Finally, we are facing misinformation with the dangers of fake news and misuse of internet resources in health decision. Although those focus areas are global, I would like to dive into 4 challenges that I have myself helping to address in developing country, such as Rwanda. The first one is limited financial resources for prevention. When I was appointed as Minister of Health in 2004 in Rwanda, we used to have, well, it was 10 years aftermath the genocide, but we're still having problems. And particularly, we used to have high indicators in maternal and infant mortalities and some other indicators. And the problem we used to have was the financial accessibility for families, specifically in rural areas. And people would not always go to the health facilities using the out-pocket money because they didn't have it. We're looking to the level of poverty we used to have at that time. So then as minister, I sat with my staff. We started to brainstorming, and I brought in my own experience when in 90s, I went to Belgium to do my PhD. Then surprisingly, what impressed me was that the first entry, I got my ID as a foreigner. Then I got also a card of Mutuelle de Santé, where I could access all levels of health facilities in Belgium. So we started to think on how we can help people, because I found they were having a smaller pilot project on helping people to get easily in health facilities. So then from my idea from Belgium, I said, as a foreigner, they catered for the permission to live in that country, but they catered also for my life. So then I told to my staff that pilot project you have to extend to take it at the national level, where each Rwandan people will only pay $2 US dollars, so he can afford per year, and they can afford the health services from the health facility, the health center, primarily for the primary care, then going up by referral and contra-referral to the specialized health services. When we started, we used to have 90% of our population enrolled in the Mutuelle. Then for us, we have broadened it, calling it universal community health insurance. Then when I left the Ministry of Health 2008, I was glad that 90% of our people were enrolled and benefiting from the services in the whole country. Even today, that tool is working very well, and the communities are accessing the healthcare without any problem. And we wish that we share with the other countries in developing world. The second one is the human resource capital capacity in health. After the genocide, most of our health professionals were killed. Others were in the prison, they still there. Others went out of the country. And the need in the community was very high in terms of prevention, in terms of treatment. So once again, with my staff and the partners in health in the government, we sat and then we said, oh, how can we find out a solution, knowing that 80% of diseases in Rwanda will be sorted out by the people at the ground. So then we decided to create a community health workers framework where we used to have woman and man supposed to cater for women pregnant and child under 5, and let alone they were also involved in fighting malaria by distributing the mosquito net. So by having 2 community health workers by village, allowed the government of Rwanda to have at least 30,000 people tackling the issue of hygiene, helping the women to go to the health centers, then also tackling the issue I have named before. So these instruments helped the government to go through the building of the capacity in the faculty of the School of Medicine, the nursing school, so they can have people also to over supervise them. It is something which has been sustained by what we do call performance-based financing, where the community health workers used to sell the indicators to the government and they remunerated on. The third one is the family planning and reproductive rights. We are in a country like Rwanda, we are so cultural, by culture, by belief in our different religions, then the ignorance, we don't not talk about sexuality. And then at that time, as I said before, we're having a high rate of infant mortality and maternal mortality due to the many children a woman could have in Rwanda. So by again interacting and brainstorming with my staff and the partners, we decided to go through fighting, tackling and sorting out the issue we're having. And we picked only one indicator, like spacing birth, where a woman where the infant, the maternal mortality was declining only by spacing 2 or 3 years between a birth and another one. And the issue was indeed to let the policy be adopted by the population, the government, and of course the parliament also, and the partners in health. So then for me, when I took the policy in the government, the president asked me one question: what is your policy coming to sort out the policy? Then I told him that for me, I would want to have Rwandan in good health, well educated, and economically strong, with all what it means. Then the president said, if is that so, your policy is approved. When it was approved by the cabinet, it gave me a way within my partners to go to advocate in implementation, and also building strategies so that we can improve at least the indicators in terms of how using the contraceptives and giving education to girls and mobilizing them around that. So I am glad that when I left the ministry, we were having the incidence rate above 45. Then now it has been improving to 53, and it has also helped to improve the infant and maternal health. And for my job and my engagement, I was awarded twice by UNFPA. And then later on, 2012, I was nominated as a superhero worldwide in family planning so that I can share my experience with others. The last one is the lack of alignment health policies. Taking the example of the family planning and reproductive rights, Rwanda has been doing well, but 10 years back, it was stagnant in terms of clear outcome. Then the World Bank, who is the bigger contributor in our development, and the Minister of Health have hired me to go deeply and to engage dialogue within the local leaders, the governments, and the religious leaders, and also key ministries like education, health, finance, and gender ministry, so that we can revamp this policy to align it to the national development strategy until 2030, or the African strategy, the development strategy 2060. So I went through meeting religious leaders, the local government authorities, ministers, and then I made a report, and I'm glad that today the outcome of my report is now being implemented to try to catch up and get the target of having the modern contraceptive used in Rwanda at the level of 70%. As I went through in my last slide, you have seen that there is, of course, the need of political commitment at national level, regional level, globally, so that you can get a solution out of any challenge you can have in implementing a policy or strategy. A comprehensive approach to improving global health must include strong political will. The leaders need to make priorities for the population health through clear policy and adequate funding. In conclusion, I propose a path forward for global health. One, to have updated models, transitioning to more flexible, faster, and sustainable health models, inclusive strategies, stronger collaboration, more focusing on prevention, and of course, to get up with a political commitment from the national to the global level. I thank you so much for listening to me, and I am ready to take questions or insight from the audience. And once again, I do apologize that I was not to be able to be online at 1 like it was promised between Melanie and me. That I hope we are done with. Thank you so much.
Thank you very much, Jane, for your presentation and also your contributions to the healthcare system in Rwanda. I do have a very quick comment and question, and then I'll leave the discussion to the other colleagues. Obviously, I like, as a public health physician myself, I like very much the emphasis on prevention, which should apply also to healthcare system in Western countries, which tend to be extremely reactive. And so we miss many opportunities in the public health domain. But obviously, I'm biased because I love the public health approach. But anyway, so I completely agree that, especially in low resource settings, prevention is really the only perhaps realistic option in terms of mitigating the multiple burdens of disease that many sub-Saharan African countries are facing. And so within that particular space of prevention, I was wondering whether you can comment on strengthening primary care. And I'm not talking necessarily about, physicians or primary care doctors, but also in terms of, family teams or primary care structure within Rwanda or other sub-Saharan African countries, which is, as you know, lacking and translate in high rates from avoidable chronic disease, starting from hypertension, stroke, late diagnosis of cancer, and so on. So if you can comment on the role of primary care within Rwanda and other sub-Saharan African countries.
Thank you, Professor. Actually, the Rwanda approach to use the community health workers in the community has been a pillar, meaning that the community workers, they are living with, or they are coming from the community. So then when they operate in the village, where today we do have four community workers in the village, it is the smallest entity in Rwanda. So they do follow the health life of the people at the village. And with that, the strategy of the health sector in Rwanda has been to interest Rwandan people. If they feel they have problem, first of all, they have to call the community health workers. And the community health workers advise to any person to go through the health center, which is the first level of intervention in our health system. Strategically, we build the health sector, the health system in Rwanda, where we hope that 80% of the problem, meaning the area diagnostic, to take tension when you go there, people are capable to make analysis of abroad and to see people have problem. So it could be handled there by the nursing, because the health center is led by a nurse in Rwanda within the staff. And then if the people can't sort out the problem, they refer the person to the district hospital, and if not, they transfer to the referral hospitals. Coming back to the cancer now, the government of Rwanda has decided to let the diagnosis, the primary diagnosis, be made at the level of the health center. With that, we are sure that the diagnosis is going to be made at the early stage. Whereas today, there are some people who go to specialty centers and it is a bit late. I have taken that also from the death of my mom, who died for cancer in 2011. I was capable to cater for her, but let alone through discussion, we say, no, we have to go to the rural area also to help those people. I've seen that if people are not taken care before at the early age, so at the end of the day, they die. So and in terms of medicine, drugs, we have to the health center, the primary level, to be sure that the essential drugs, medicine, are available through a center which we built as a central distribution for the health facilities, not as a key, as a main one. So the people do not have to go first through private pharmacies to look for primary.
No, Gene, thank you very much. This is very clear. I just want to leave the space because we're running out of time. We still only have 6 minutes. So I don't know if there are questions or comments from others.
I have a question.
Yes,
on the tech component, what do you think is feasible and practical for Africa in terms of making technology available both for diagnosis and treatment and accessible to all population sectors?
Not easy, but I think if government would understand the importance of having the tech innovation so that people can benefit from developed country, like if you are in Western, so then collaborating with the hospital of Rwanda, so then you can help people by tech. But you know that Rwanda, from the leadership level, has been engaged in availing technology at all levels in our health facility, in our life, but in particular in the health sector, because from the president, the government know that if we do have facilities in our hospital, let us say at the referral level, because it is costly, but at least people in need could be referred there with the medical doctors and team specialized to help people and benefit from, and allowing them also to exchange with other institutions abroad.
Thank you.
Thank you. I think there is a question from Asham.
Yes. Thank you very much, sir, for the interesting talk. I wanted a sort of a clarification or elaboration. You had mentioned one of the challenges being that there was lack of private sector engagement. I was wondering, what kind of engagement are you looking for in the private sector, and why is the lack of a private sector seen as a problem?
Thank you so much for the question. You see, from the origin, you have seen private sector only involved in pharmaceutical sector. So today, if we need to have a global or a holistic health approach, like it is happening, is also to encourage private sector to invest in health delivery, being it in the lab as for the diagnosis, being it to build health facilities, not to leave it alone to the government because the financing is also heavy for all. Then to have them in research. We have had that in Africa or in developing countries that the mission was left alone to the government, but the government also used to set up policies and facilities to let private sector to come in, then invest, but also have the return. When you have a country like Rwanda, where we have a strong system of health insurance, not only the community health insurance, there are also another insurance for public services and the military corps, where anyone is able to pay the cost on the services you get. You can easily involve the private sector coming in, unless of having what we used to have in Africa or developing countries, where there was the state, then the NGOs, and or the religious confession. So we want the private sector to inject their money in strengthening and building a stronger health system, where the government assure them for the regulation and
But if you don't mind me asking a follow-up question, it seems if you're having the private sector acting more than just vendors, then you'll increase the other two challenges you were mentioning, where you're going to increase fragmentation, and then you are transitioning even more authority or capability from the government to the private sector, and will therefore reduce political will. So this challenge ends up exacerbating two other challenges, which would be more systemic.
No, perhaps, but you have to build also a clear partnership between the state, the private sector, and the community, where everyone has its clear role. Me, I do believe that the private sector is within a good policy framework, where clearly everyone sees its role in developing the health sector and the services, can help. And the government is always there to set up regulation to helping the people, the policy to help people who want to be involved in that, to enjoy the role it has to do. Perhaps we shall continue to discuss about that issue even the time comes, and I will want to have also your idea on that, because perhaps I don't give more. But from what I did, I was also ready to, and I have done, to involve the private sector to be also capable to give the contribution.
Thank you, and happy to discuss further.
Yeah,
Yes,
thank you so much too.
that will be a discussion for a symposium. I have the very last question from Dr. Reader, and then we need to end the meeting. Michael, please.
It's just a short follow-up question. Thanks very much for your talk. Greatly appreciate it, and very, very, very illuminating. Does Rwanda have a private pharma sector? Because it strikes me that many times companies that or countries that invest in pharma do so with the assistance of a domestic pharma sector. And I'm just wondering if Rwanda has one.
Yes. As a pharmacist who taught to the pharmacist, the oldest there. No, we do not have much as an industry in pharmacy, in the pharmacy sector. What we do have is pharmacies, but within the COVID, we have had we do have private people who are building a center on for vaccine and medicine, and we have also now Rwanda is hosting the African drug medicine for the whole African Union, which is going to helping also to have pharmaceutical facilities in many countries, and within the Eastern African region, we are also having a framework to see how we should be autonomous by producing some of the drugs which are used in dairy instead of always importing from abroad. So the biggest one, the biggest source we do have today and in all Africa, and you have seen it even within the COVID, where everything was coming out of our continent. From the African level, Rwandan level, we are now having we have started to set up facilities to help us to become at a time autonomous.
Thanks very much. Really appreciate it. Great.
Thank you so much too.
Thank you very much, Jean, for your presentation, and we look forward to additional opportunities to interact with you and perhaps with you in-person visit to Western University in the near future. Thanks everyone for attending the monthly Media African Institute. I think